Imagine walking into a plastic surgeon's office. You sit down, expecting the standard procedure you see on TV where they just take out a digital tool and shave down a bump on a screen.
Right, the classic, take a little off-the-top approach.
Exactly. But instead, the surgeon looks at your profile and says they actually need to build a literal skyscraper in the middle of your face.
Which is such a wild thing to hear as a patient.
Totally. So welcome to the deep dive. Today, our mission is to decode the hidden, highly specialized engineering behind Asian rhinoplasty.
And we have some amazing source material for this. We are looking at clinical notes and insights from Dr. Shim Ching.
Right, he's a board-certified plastic surgeon in Honolulu, Hawaii, who has spent 25 years in this specific field.
25 years is a massive amount of time to study one very specific anatomical structure.
It really is. And we're going to explore how achieving a natural, long-lasting result isn't just like an artistic endeavor. It's an intense exercise in structural architecture.
Yeah, and the central paradox of this entire field is exactly what you just described. It's the hurdle that completely catches patients off guard.
Because if you go to a mainland U.S. surgeon, someone whose primary training is in Caucasian rhinoplasty, their ingrained instinct is reduction.
Oh, 100%. They are trained from day one to make the nose smaller. They want to lower a high bridge, narrow the tip, just take away cartilage.
But for Asian rhinoplasty, the biological baseline is entirely different.
Exactly. The goal is the exact opposite. You aren't trying to reduce at all. You are actively trying to augment.
It's like the difference between sculpting and construction.
Oh, what, like that?
Yeah, like Caucasian rhinoplasty is sculpting, you're carving away a block of marble, but Asian rhinoplasty is construction. You have to pour a foundation, put up scaffolding, and build upwards.
Right, you're adding materials.
Yeah.
And to understand why this massive undertaking is necessary, you have to look at why that standard westernized approach just completely fails for Asian patients.
Because it ignores the fundamental anatomical reality of the person sitting in the chair.
Exactly. In Asian rhinoplasty, you were usually dealing with naturally lower and softer structural supports. You have a low nasal bridge and often a flat tip that lacks forward projection.
And the sources mention sometimes the base of the nostrils, the alar base, needs to be narrowed to reduce flaring.
Yes, but the primary vertical and forward movements are all about adding volume. If a surgeon just defaults to standard reduction techniques on an Asian nose,
Taking away cartilage that's already soft and thin.
right, the result doesn't just look artificial. The nose literally loses its structural integrity. It can collapse.
Which is terrifying, because that compromises not just how you look, but your actual ability to breathe.
Exactly. Form follows function.
The sources also mentioned this highly relatable functional detail about having a low bridge. They called it the glasses test.
Oh, yeah. The sliding glasses. It's such a common complaint.
Yeah, if you have a naturally low nasal bridge, which is super common in Asian anatomy, your glasses are constantly sliding down your face.
Because there simply isn't enough of a physical, bony shelf there for the frames to rest on.
So you're just functionally pushing your sunglasses up your nose all day?
Right. And the glasses test really highlights why seeking out a surgeon who understands this exact facial anatomy is strictly non-negotiable.
Dr. Ching's notes really hammer this home. He emphasizes that you, as a patient, should be looking for a surgeon with at least 10 years of dedicated experience specifically performing Asian rhinoplasty.
10 years.
Yeah.
Minimum. Because the learning curve for facial construction is incredibly steep.
Yeah, a surgeon needs to have followed their own patients for a decade to see how the biological materials they used actually hold up over time.
Exactly. If a surgeon hasn't seen how a tip graft behaves at year 7 or year 10, they don't truly understand the architectural load they're placing on the nose.
Okay, so let's get into that architecture. If the goal is to build that bridge up to raise the roof so those glasses stop sliding down, what materials are the builders actually using?
Well, the bridge of the nose is basically 2 parts. The upper third between the eyes is solid bone, and the lower portion leading to the tip is cartilage.
So what are we putting on top of that to build it higher? Because the source material reveals a massive, almost philosophical divide between the U.S. and Asia here.
The divide is completely polarized. In the mainland U.S., surgical training heavily favors harvesting your own biological tissue. They usually go straight for rib cartilage.
Right. There's a technique the sources mentioned called DCF, diced cartilage fascia.
Yes. To do this, they take a piece of your rib cartilage, chop it up into tiny minced pieces, and then wrap it in a layer of tissue called fascia.
Fascia. I'm trying to visualize what that actually looks and feels like inside the body.
Have you ever prepped raw chicken breast? You know, that thin, tough, silvery membrane clinging to the outside of the meat?
Oh yeah, that stuff is stubborn.
That's fascia. So surgeons harvest a piece of that from your body, often from the scalp area, wrap the diced rib cartilage inside it, like a biological sausage casing.
Oh wow, a biological sausage casing. That paints quite a picture.
It really does. And then they lay that across your nasal bridge to build it up.
That sounds incredibly labor-intensive, not to mention you're creating multiple surgical sites on your own body.
It adds significant time to the operation and subjects you to a much harsher recovery. But if you look at Asian countries, particularly South Korea,
Which is universally recognized as the innovation capital of the world for this surgery, right?
oh, without a doubt. And in South Korea, they overwhelmingly reject the diced cartilage method for the bridge. They use silicone implants. Millions of successful procedures, almost all utilizing silicone.
Wait, hold on. This is where I have to step in for the listener who is suddenly very alarmed. Is it actually safe to leave a piece of synthetic silicone just sitting inside your face?
It's a completely valid question.
Won't your body eventually recognize it as a foreign object, attack it, and just, push it out? Why is the U.S. so terrified of silicone if South Korea uses it as the absolute gold standard?
Well, that fear in the U.S. stems from a very specific mechanical failure in older surgical engineering. About 20 years ago, the standard practice globally was to use an L-shaped silicone implant.
Okay, L shape.
Imagine a solid, rigid piece of silicone shaped exactly like a capital letter L. The long part went down the bridge of the nose, and the short part hooked right down into the soft tip to forcefully push it forward.
I'm visualizing that rigid shape. It seems like it would instantly give you a very sharp, highly projected tip.
It did initially. But think about the underlying physics of that design. You have a rigid, unyielding piece of synthetic material constantly pushing outward against the soft, delicate skin of the nose tip.
Oh, I see where this is going.
Yeah. It created massive, unrelenting tension. Over time, that constant physical pressure caused the skin at the tip to thin out, and eventually the implant would extrude.
Meaning it would literally push its way through the skin of the nose.
Exactly. Right through the skin.
Oh man, that is an absolute nightmare scenario. I can completely see why U.S. surgeons saw those complications and got entirely spooked.
When a surgeon sees a failure like that, the human instinct is to blame the material. But the silicone itself wasn't the problem. The physical application of tension was the problem.
So what changed? How do they do it now?
Modern techniques have entirely abandoned that L shape. Instead, they use what's called a dorsal implant. It's a smooth, carefully carved piece of silicone that sits strictly on the bridge of the nose.
So it just rests flat on the bone and upper cartilage.
Exactly. It does not extend into the tip at all. By removing the silicone from the tip, you remove 100% of that dangerous tension.
And the body is just okay with it being there.
Yep. The body simply forms a microscopic capsule around the smooth silicone on the bridge and happily ignores it for decades.
Okay, but if you use your own rib cartilage on the bridge, the way the U.S. surgeons do with that diced sausage method, at least it's your own tissue. Doesn't that make it more stable in the long run?
Actually, it's the exact opposite.
Wait, really?
Yeah, biological material comes with biological unpredictability. Cartilage has a microscopic grain to it, very much like wood.
Oh, interesting.
If you carve a solid piece of rib cartilage, it has tissue memory. As it heals, it actively tries to warp and bend back to its original curved shape inside the chest.
So you could leave the operating room with a perfectly straight bridge, and 6 months later, it is visibly warped to the left or right.
Exactly. And the sources also mention something called resorption happening with biological materials.
Right. What exactly is the body doing during resorption?
Well, when you move cartilage from the rib to the nose, you are severing it from its original robust blood supply. The body's immune system sends in macrophages.
Those act like cellular garbage disposals, right?
Spot on. These macrophages patrol the area, find this unsupported, poorly vascularized tissue, assume it's debris, and slowly start eating it away. That's resorption.
The cartilage literally shrinks.
Yes. You might have a great result at month 6, but by year 5, a significant portion of the bridge volume has just vanished.
Wow, and a modern silicone dorsal implant is immune to all of that.
Completely immune to both warping and resorption. It looks exactly the same 20 years from now as it did the day it was placed.
So the logic for using silicone on the bridge is pretty airtight. But because silicone is now strictly banned from being used in the tip of the nose due to that extrusion risk, what on earth do they use to build up the tip?
That's the million-dollar question. Because the tip requires flexibility to withstand the constant daily movement of your face.
Right, from talking, smiling, frowning, all of that.
Exactly. Surgeons are forced to use biological material for the tip, and this forces them to look at the available options within the human body. It essentially presents a cartilage menu.
Let's go through this menu because the engineering required for the tip sounds intense. The sources describe the tip as a complex, load-bearing framework.
It absolutely is. It controls three critical things: projection, which is how far the nose sticks out; rotation, which is the angle of the tip; and long-term stability.
And if that foundation is weak, the whole structure slowly collapses.
Right. So, looking at the biological menu, option 1 is the septum. This is the flat plate of cartilage inside your nose, separating your nostrils.
Which sounds incredibly convenient, since the surgeon is already working right there.
It's the ideal choice when it's structurally sound. It's straight and rigid. The problem is, in a large percentage of Asian patients, the natural septal cartilage is very thin and quite small.
So it simply doesn't provide enough raw, weight-bearing material to build that heavy-duty structural support.
Exactly. You can't project a flat tip forward with a flimsy piece of cartilage.
Okay, cross the septum off the list for a lot of patients. Option 2 on the menu, the ear.
Ear cartilage is incredibly accessible. But, if you reach up and feel your own ear right now, you'll notice it's soft, squishy, and naturally curved.
Yeah, it bends super easily. It's fantastic for subtle refinements, maybe, but it lacks any real density.
Right. Trying to use ear cartilage to hold up the entire nasal tip would be like trying to build a load-bearing wall out of drywall instead of solid wooden beams.
That is such a good analogy. If you put the constant weight and tension of the nasal tip on that drywall, within 5 years, the entire structure just crumbles under the strain.
The tip droops. The projection is lost. So because the ear is too weak, the surgeon is forced to look for the only structural beam in the body thick and strong enough to bear the load.
The ribs. The ribs. Just hearing the phrase rib cartilage harvest makes me wince.
From a purely engineering standpoint, it's perfect. It provides a large, strong, remarkably straight piece of material. Surgeons use it to build what's called a septal extension graft.
Think of it as a central pillar that anchors deep inside the nose and pushes the new tip forward with absolute, unyielding stability.
That's exactly what it does. But the human cost of getting that material is severe.
Dr. Ching's notes point out that harvesting a piece of your own rib involves a completely separate incision on your chest.
It leaves a visible scar. It adds significant time and expense to the surgery.
And the recovery sounds agonizing. He describes it as feeling like you've literally broken your ribs. Every time you take a deep breath, every time you cough or laugh, you are in sharp pain for weeks.
Which brings us to a massive leap in medical availability. How do we get the undeniable structural perfection of rib cartilage without the agonizing recovery of chest incision?
Dr. Ching introduces a phenomenal alternative here. Flash-frozen donor cartilage.
It's a game changer.
Hold on, though. You're saying you can just order someone else's rib cartilage off a shelf. Isn't your body going to treat that exactly like a transplanted organ like a kidney and send the immune system to attack and reject it?
It's a highly sophisticated process that prevents that entirely. The tissue is responsibly sourced from human donors and meticulously screened. But the crucial step is the treatment.
What do they do to it?
When the laboratory flash freezes and irradiates this cartilage, they're essentially wiping it clean of the living cells, the DNA markers that trigger an immune response.
So what's left behind?
Purely the architectural collagen matrix.
Yeah.
The scaffolding.
Oh, wow. So it's like taking a house, stripping out all the personal furniture and paint, and just leaving the bare wooden studs. Your body doesn't recognize it as a foreign invader because all the identifying markers have been washed away.
That is precisely how it works. The surgeon takes this sterile, highly stable matrix off the shelf, thaws it, and carves it. It behaves almost identically to the patient's own rib.
It allows the surgeon to build those strong, stable central beams for the tip without adding hours to the surgery.
And the patient wakes up without a painful chest wound. It fundamentally alters the recovery blueprint.
Okay, so we've built the bulk of the skyscraper. We have a smooth, highly stable silicone implant sitting cleanly on the bridge. We have incredibly dense donor cartilage acting as the foundation to project the tip forward securely.
But we aren't quite finished.
Right. The sources talk about one final critical step to harmonize the whole structure, and that's narrowing the wide, bony base.
Because if you just build up a wide nose, you end up with a massive structure. You have to bring the side walls inward.
To physically bring those side walls closer together, the surgeon has to make precise cuts in the solid nasal bones on either side of the nose.
And the traditional way of doing this sounds like something straight out of a medieval blacksmith's workshop.
Oh, yeah. They use a tool called an osteotome, which is essentially a surgical chisel, and the surgeon uses a literal hammer to tap it through the bone.
It is highly effective, but incredibly traumatic to the surrounding biology. When you use a physical chisel to forcefully break bone, you invariably crush and tear the delicate soft tissues.
The muscle, the tiny blood vessels that tightly encase that bone.
Exactly. That immediate internal bleeding is what causes the severe black eyes, the deep purple bruising, and the massive facial swelling that everyone traditionally associates with rhinoplasty recovery.
But there is a modern innovation to replace the chisel that sounds like pure science fiction. It's called the piezotomy.
Yes, the ultrasonic saw.
It's arguably one of the greatest advancements in facial bone surgery, right?
Without a doubt. Instead of a physical striking force from a hammer, the piezotomy uses high-frequency ultrasonic vibrations to cleanly cut through the bone.
Wait, how is it possible to use a vibrating saw blindly inside the narrow cavity of a nose without completely shredding the delicate skin and the blood vessels all around it?
Think of the piezotomy like dragging a vibrating tuning fork across two different materials, a rubber band and a delicate glass rod.
Okay, I'm with you.
If you press that vibrating metal against the rubber band, the rubber just wiggles. It absorbs the frequency without taking any damage. But if you press it against the rigid glass rod...
The glass instantly shatters.
Exactly. The piezotomy is tuned to a frequency that only disrupts dense, mineralized tissue like bone. The soft tissues, the nerves, and the blood vessels just absorb the vibration and bounce out of the way.
That is incredible. So the bone is cut with laser-like precision, but the surrounding vascular network remains completely intact.
No torn blood vessels means almost no internal bleeding.
And no internal bleeding means drastically less bruising and swelling.
The difference in the patient's recovery is staggering. A patient whose bones were cut with a traditional osteotome might be severely swollen and sporting deep black eyes for weeks.
While a patient treated with an ultrasonic piezotomy might look entirely socially presentable in a fraction of that time, often with little more than mild puffiness, this all paints such a clear picture of how highly optimized this specific surgery has become. If we synthesize everything we've uncovered from Dr. Ching's insights, it really outlines a definitive playbook.
I agree.
We could call it the 3 pillars for the shortest recovery in Asian rhinoplasty.
Let's hear them.
Pillar 1. Use a modern, tension-free silicone dorsal implant for the bridge. Your body doesn't react to it. There's no massive swelling from the macrophages causing tissue resorption, and it never warps.
Solid. Pillar 2.
Pillar 2. Use flash-frozen cellular stripped donor cartilage for the tip. You get world-class structural support without the agonizing pain of a broken rib and a chest scar.
And pillar 3 is the bone work.
Right. Demand that the surgeon uses an ultrasonic piezotomy saw for the bone work, bypassing the trauma to your blood vessels and skipping the black eyes entirely.
Those 3 pillars highlight why understanding the mechanics is just as important as the aesthetics. A successfully engineered rhinoplasty shouldn't just look good in a carefully lit photo at month 6.
It needs to remain structurally sound, with perfect airway function and tip support at year 10 and year 20.
The ultimate goal isn't to create a nose that draws attention to itself. When the architecture is correct, the nose practically disappears from conscious view. It brings the patient's entire face, their eyes, their jawline, their natural ethnicity into elegant, effortless balance.
You want people to look at you and say, you look amazing, not who did your nose.
Exactly.
So what is the ultimate takeaway for you from this deep dive? It's that being well-informed isn't just about learning cool medical trivia. It is about knowing exactly how to advocate for yourself.
That is the most important part.
If you were sitting in a consultation room considering this procedure, the most crucial conversation you can have with a plastic surgeon isn't just handing them an inspirational photo from your phone. You have to interview them on the architecture.
You need to ask, what specific materials are you using for my bridge versus my tip? What is your mechanical strategy to ensure my tip won't slowly collapse over the next 5 years?
Are you using a chisel or an ultrasonic saw? And most importantly, based on Dr. Ching's advice, do you have over a decade of experience specifically managing the unique structural demands of Asian facial anatomy?
If the surgeon cannot give you a clear, structurally sound answer that accounts for the long-term physics of your specific anatomy, you are simply in the wrong office.
Absolutely. The engineering matters just as much as the art. And as we wrap up, I want to leave you with one final, lingering thought that builds on everything we've discussed today.
Let's hear it.
We talked about how flash-frozen, decellularized donor cartilage is currently revolutionizing facial architecture by eliminating the need to harvest our own ribs for spare parts. But what does the future of that technology look like?
It's a huge question.
Are we entering a medical era where off-the-shelf, donated biological scaffolding will seamlessly repair or enhance any structural weakness in the human body? Imagine a near future where the line between natural biology and architectural upgrades becomes entirely blurred,
Oh, my.
where repairing a degenerated joint, rebuilding a shattered jaw, or reinforcing a failing spine is as simple as a surgeon ordering the perfect, immune-invisible biological beam from a freezer. Something to think about. Until next time on The Deep Dive.